It's a short lecture. It's just an introduction to what we'll be practicing tomorrow. It's about the suture and suturing techniques, okay? We just learn about a few things, like the suture classification. In my practice, a strange thing, or it might be common thing, is that the doctors in your level, or even more advanced in a non-surgical branch, they do not know what is the meaning of suture, how to request for a suture. So for sometimes I am just asking the resident doctor to bring me some type of suture, and they are just embarrassed that they don't know how to write that, how to request for some kind of suture from the responsible nurse or pharmacist, okay? So this is the basics you need to know when you are a non-surgeon or in a non-surgical branch, when you are resident, or later on when you become in a non-surgical medical specialty. The second thing is that the needle types, not all the needles is the same, it's different. And then the suturing material, what is the suture made of, and the suturing techniques and surgical noting, and which is will be discussed in details tomorrow. The first thing, what is suture? The term suture is not the act. Suturing is the act when applying a suture into something. So suture is the material, which is this thread. This thread is called a suture. So not the whole construct is a suture. This is a thread which is called a suture, which is connected to a needle. This is the term. So when we say a suture, we mean this material, this thread, okay? So in medicine, we call it a suture. So the suture is sterile, which is almost should be sterile because it invades the body, and it's suturant, used to approximate tissues and to promote healing in a specific way. We need to reach that level. So we just keep the tissue in some position, and later on with the mesenchymal cells and the healing and inflammation, everything will be fixed by the body immune system. And also for the hemostasis, yeah, because sometimes we just ligate the vessels on things to promote hemostasis. The first thing, the classifications of sutures. So the material of sutures can be classified into absorbable and non-absorbable. We are not discussing the needles. We are just talking about the threads, okay? Is that clear until this point? Absorbable versus non-absorbable. You know that the absorbable can be hydrolyzed, or proteinolysis effect will degrade that suture and make it absorbable via the immune system. The non-absorbable is a permanent suture inside the body. It could be natural and or synthetic. The synthetic should be absorbable, but the natural is have a absorbable and non-absorbable types. The monofilament versus the multifilament. Even in a daily life, we have this rope which is made of polyfilament, which is made in some way connecting multiple threads to form a larger structure, and the monofilament is something like a pipe, or it's a structure of a single thread. It's not a multiple thread together. There is the absorbable versus the non-absorbable. This is the some types of the absorbable, like vicryl and monocryl and the PDS, and its idea is that loosening string over the time. So the good thing is that you don't need to remove it, and it will be absorbed by the body from its own. But the bad thing is that it will not give a permanent support. It will lose its strength over time, and it's liable to break after a specific period according to the manufacturing of that thread. The uses, it's for use mostly in internal tissues, because we don't need to reach that tissue later on and invade the body in order to extract these sutures, okay? About the non-absorbable sutures, we have the nylon, acrylic, and silk. These are permanent. The silk might be not a permanent, it can be degraded, but within a very long time, many years, so it could be considered as a non-absorbable. It have a permanent structure. It will not be absorbed unless it's removed, so it's still in the body, and we use it to close the skin and vessels. The vessels, because we don't need the vessel to be opened later on, so we need it to keep permanently inside to keep that vessel closed. And in the skin, we can remove it because it's superficial, so we use a non-absorbable, okay? We have a monofilament versus polyfilament. the threads, some of the thread is formed of monofilament. Tomorrow we'll see that in practice, and we'll hold them in our hands. The nylon type of the monofilament, all of the monofilament, is hard to be handled because it have a shape memory or elastic memory. So when you just straighten the thread, it will return for its original shape. So in handling and suturing, you'll face that tomorrow when you are practicing. It's harder to handle, but it's giving a stronger structure, and it have a less risk of infection. And that's making sense because it's monofilament. It have no multiple spaces inside. It's just one structure, so there's no place for the bacteria to grow inside these foreign bodies, okay? Because the suture is a foreign body, you know. Regarding the polyfilament, it's have a better handling, but with a higher risk of infection. So they invented this hybrid type, which is a polyfilament coated. So it's from inside, it's a polyfilament, have these advantage of a polyfilament, which is an easy handling, but it's coated with a silicone or waxing some material to give it a smooth outer surface to avoid the risk of infection. Is that clear until this point? Yes. This is the science of needle. The needle itself is a science. You need to understand why every specific thing in this needle is designed like this. We have the needle, I don't know if the laser is visible, the needle points or the head, the tip of the needle. We have the diameter of the needle. We have the radius of the circle of the needle, because most of our needle are curved, and we have also a straight needles, but it's more rare. And also we have the swag, which is the connection between the thread, the suture, and the needle, and then we reach the already known suture. Okay. The first thing is the tip. This is a slide regarding the needles type. When you're choosing, when you are the person who's responsible, we say that you are the doctor, we are giving an orders, and other is just following. So you will take the decision. So the nurse or the pharmacist will ask you which type of needle do you want, and what should I bring to you. So you should specify. You are the one who specify. When you are choosing the needle should be chosen according to the tissue you are working on. It's not dependent on the strength of the suture. It's not dependent on of the type of the suture. No, it's dependent on the tissue. So the cutting needle, which is have a cut edge like this one, it's sharp, so it can penetrate the tissues easily. So it tears the tissue. It's not just spreading them. It cuts the tissue and go through. So we are just using it in a rough tissue that is that can adapt a harsh or a traumatic suturing. Okay, this is a type of cutting. We have a reverse cut. That is the cutting when the sharp edge is inside, and the reverse cutting when the sharp edge is outside of the curve of the needle. Tomorrow we'll have more details about these different things. So it's used in a multiple area, but as in general, the cutting needle will tear the tissue and go through. So you won't use it in a friable tissue like a muscles, like the visceral tissue, or subcutaneous tissue or a fatty tissue, because it will tear that and you will not get the benefit. The topper is used for the soft tissue, which will have a cutted end but a round needle. So only the tip is cutting. So it cuts a small opening in the tissue, and then it will penetrate through a rounded needle that will cause less trauma. So that is less traumatic, which is used in the soft tissue. And this is the blunt, like this one. It have a round tip and a round body. So that is spreading the tissue. It will not cut. It is just spreading its way between the cells of the tissue, and it will not cut it. And it's used for a friable tissue, specifically the muscles. The muscles is formed of many fibers. So whenever you cut the muscle, it will be sheared along its way. So you cannot cut the muscle during suturing, and you try to preserve as much as possible. Then the curvature. There's many shapes of the needles. Everything is written on the cover of the needle, but of the suture, sorry. But in main practice, we have a half circle and the 3/8 circle. This is the types that's most commonly used. The idea behind this: the more curved needle, the more curve, which means it's easier for the needle to go in and go out easily. So when we have a deep tissue that we cannot control, the more curved needle will give us an easier in and out in one go. You do not need to go in and then change the direction and going out. So in one direction, and tomorrow we'll discussing a practical thing, because the radius of the needle and the round shape will go with your supination. So you should never use your elbow or shoulder in this. You will just do a supination, and that should be enough for the needle to go in and go out, and you will find the tip, and then you take out the tip and you just pass it tissue. Is that clear? The more superficial, we need a less curve. Even a straight needle will be useful, and superficial and very superficial things, because you can just pass the needle straight forward and take it from the other side because you are controlling it well. It's not that deep. This is regarding the principle of suturing. Gentle tissue handling. So you don't need to go in multiple entries. You do not need to fry or tear the tissue during suturing. So you need to be gentle and trying to get your stitch or your suture from the first go. That is the best thing to save the tissue. The second thing, the proper tension. You do not need to tighten it as much as possible, because that will impair the microvascularity, because of the pressure created will cause interrupted vascularity to the tissue and cause a necrosis of the skin later on. So you need it to be just enough to touch. It's called kissing. So you just touch a lip to another lip of the skin. You do not need to over tight it and make it overlap. Okay, so it's just touching the skin edge to each other. That is perfectly enough. Everett wood edge. When the tissue is sutured, it's better to have its edge going up rather than going down. So when tissue edge is going up, the epithelialization is, when it's created, it can cover this area, the raw area kept between these two edge. But if it's inverted, it will cause the epithelial tissue along with its normal floral bacteria to go inside the body, reaching an internal dermal or even subcutaneous tissues, which is not adapted to protect against this bacteria and will cause infection at the site. And also with healing, the ectoderm can create only an ectoderm, the mesoderm can create only a mesoderm. So when you enter the ectoderm inside the mesoderm, healing will not occur. Okay. Maintain symmetry, which means when you are tightening on one side, you're trying to keep tension equal on each side. You don't need a side to be loose and the other side is just pulled towards this direction, and keeping tension on one side of the suturing. These are the types of suturing. We'll be practicing that tomorrow, but we are just giving an idea about it. This is the simple interrupted, which the type we'll be using. Everyone is using it. It's the simplest thing, but it's very important because this is the gold standard suture, and it's very common to be used because it have not that disadvantage. So it is one of the most common and it's the most effective. Do not underestimate this type of suture. It's a simple interrupted. We just go from one side of the skin going inside the body and going out from the other wound edge, then going out from the skin and just tightening each one to another, and it's interrupted, simple interrupted. So we stop. So each suture we take will not affect the second one. If we have disrupted one of the stitches, it will not affect the next one. Okay. This is a continuous. It's the same as symbol, but it's a continuous. So when one of these stitches fails, it will fail all the chain before and after because we lose the tension on the wound. Okay. So this is a continuous. We are just going around continuously without tying a knot, and later on at the end of the wound we are tying one knot, and at the beginning we tie a knot. If there is a cut in the suture at one point, all the wound will be disrupted. Okay. Sorry. The subcuticular, which is most commonly known for the cosmetic reason, this can be used via an absorbable or a non-absorbable. Okay. In the absorbable, you can even keep the knot inside the body and everything enclosed, and it will be permanently kept. You will not remove the stitch and will be absorbed via the body immune system. Okay. In the non-absorbable, you need to keep the knots at each side visible, and then you can just pull it out and it will be gone. Okay. The advantage of this suture is that there is no skin marks, because in the previous sutures we have these area of the skin penetration on the sides, and it will keep a mark. In this type, it will not keep a mark, but this is a weak suture. We are just depending on the derms. We are not using the hard, rough epiderms to secure the suture. So we need to suture that under no tension. So we take layers. We take the first layer, second layer, the third layer, until we have a wound with not much tension with this suture. If we have a tension with this suture, it will be ugly and it will do more harm than a benefit. Okay. This is a vertical mattress, especially designed to keep everything in tension, so you close it strongly. Unfortunately, this is the right drawing, but the needle do not show the reality of it. We go from far to far and then near to near. So we go like this, and we just enter again from the far side and enter the skin again, and the knot will be from one side. Is that clear from the? We'll be discussing that in more details tomorrow when we are doing it practically. Semi-buried vertical mattress, it's like this. So in the vertical mattress, the normal one, we are just going out from the skin and re-enter, but in the semi-buried, we are just going inside the tissue and again out without penetrating the far side skin. Is that clear? So we're just keeping it inside, and these have as two strands going outside from one side only. It's very useful in avoiding disruption of the vascularity, as we say it in this area. So these are the vessels in the epiderms, in the derm, sorry. So our suture should interrupt them less than when we take it to the skin and going back in again. So this is the idea behind it. Surgical notes, the principle of tying, it should be secure, flat as much as possible, not overly tightened. And the types is square knot, surgeon's knot, and sliding knot. These are the common things. The difference, I don't know if I have a slide about this. The difference between the square knot is that you are tightening suture in one direction and then tighten the second one in the opposite direction. It's like when you are tying your shoes, you just tie it in one direction and then tie it in another direction, so it will avoid be loosening over time. The tension will create more secure to the knot rather than loosening it. Tomorrow we'll have a more practice about this specifically. The surgeon's knot, we are taking two knots first in the same direction, then we reverse it to the other direction to have a square knot later on. The sliding knot, we have a multiple knots in the same direction, then we can slide the knot. After tying it, we can slide it toward the body, so we start with a loose knot, then we tighten it as much as needed, then we locked it with a square knot. And also we'll practice that tomorrow, Ayush. Okay. We have we can tie a knot via the instrument or via hand. We can use our hands to tie a knot. We'll learn that tomorrow, I wish. And we have the typical instrumental tying. There's some difference. The instrument is faster, but with the hand there is more control. So when we need a more control, some surgeons do it just because it's more funny or more comfortable for them. So just doing a hand notes. Especially who are the orthopedics, we are doing a lot of hand notes. When like getting some vessel or things like that. Yes. Yes, yes, I'm not a general surgeon. Dr. Lake knows how much about these things more than me. But yes, in the ball and stenosis, it's using a hand to have a more control. It's the basic. Common mistake with the surgical knot: if it's too tight, it will cause ischemia. If it's too loose, there will be no kissing or a touch between the edge, and it will cause a wound dehiscence. And if it's uneven, it will cause an ugly scar and improper healing, maybe infection. This is the most important part of this lecture. If I am a surgeon, I requested from you, دكتور العفو روح اكتب للأهل خلي يجيبوا لي خيط نايلون 5 أصفار. هذا المصطلح العام دائما، أو 3 أصفار. دكتور روح اكتب لي لها يجيبوا لي خيط نايلون 3 اصفار، وهنا تبدا الصدمه. I don't know. What should I write exactly, doctor? Can you confirm to me? Can you teach me? Can you write it by yourself? Most of the doctors doing that. All of the non-surgical doctors is doing that, actually, all of them. Okay, so this is the formula that is internationally and locally accepted. So when I'm saying دكتور جيب لي خيط 5 اصفار، انا ما اروح اكتب 5 اصفار واحد بصف الثاني، وهذا الكومن ميستيك يعني. اوكي، ما اكتب 5 اصفار واحد بصف الثاني، يعني هو هذا اللي هواي صاير، يعني كلش هواي زين. حتى اعتقد يعني الصيادله متعودين على هذا الشغل، انه الطبيب يكتب 5 اصفار واحد بصف الثاني، يكتب بصف فتشي، وهو هاي اللي يقول لك دكتور انت قلت لي 5 اصفار نايلون، يعني شو اكتب 5 اصفار نايلون. فهي هاي الطريقه الصحيحه. 5 اصفار 6 اصفار برولين اوف كاتنج نيدل. هسه احنا صراحه يعني الكاتنج نيدل احنا مو كلش اورينتد، حتى الصيادله او النيرسز مو كلش اورينتد انه يفتهم هاي كاتنج نيدل، وانه الطبيب ما يقبل اذا جبت له راوند نيدل. احنا راح نشتغل بالموجود. هسه حتى داخل صاله العمليات كسيرجنز لما يجينا نايلون واربع اصفار ومو كاتنج راوند نمشي الامور، يعني ما راح اقول له لا خلاص هذا السوشر ما راح استخدمه، واضح؟ فور جيفنج يعني انت بالنهايه اذا ما كتبت تايب اوف ذا نيدل، هو كل الناس ما تكتب، بس ممكن انت سبيسيفيكلي تريد نيدل تضيف تايب اوف ذا نيدل، فهذا البارت فور جيفنج هذا يعني ممكن. بس هذا هو الريكوست الطبيعي، الطبيب اللي ما يكتب هاي الريكوست يعني صعب صراحه صعب. فهذا هو اكثر يعني سبب المحاضره الثيوري، انه احنا نتعلم شلون نكتب النايلون الاوردر للريده. فهسه احنا ان شاء الله راح نتعلم او راح نفتهم بمرور الوقت انه كل نيدل الياتي شو نستخدمها. فالسكين نستخدم له كاتنج زين، ونستخدم له موستلي نون ابزوربل اللي هو مثلا نايلون، واضح؟ ونستخدم السايز المناسب. اذا بالفيس بالهاي مرور الزمن راح تتعلمون هاي الاشياء، يعني يقول لك دكتور اذا بالوجه غالبا استخدم 5 اصفار او 6 اصفار، اذا باقي الجسم استخدم 3 اصفار 4 اصفار، اذا عندك فد تريد تنشننج على يعني عندك فد اوبن ووند وتريد تسوي له ابروكسيميشن، يعني تحاول راح يصير تنشن على السوشر، فنستخدم 0 إلى 0. اذا قال لك دكتور جيب لي خيط 1 أو 2 مو اصفار، اللي هو عندنا 1 و2 اكبر من الصفر، واضح؟ اللي هو يكون اكبر شيء 1 و2 وممكن 3. ف1 و2 هو مجرد تكتب 1 بصف الرقم ما راح تواجهه بمشكله. خيط 1 نايلون، واضح؟ بس الاربع اصفار هاي طريقته، 3 اصفار نايلون، 4 اصفار نايلون، يعني بليز زين ان شاء الله يعني مجرد تعرفوها مره واحده بحياتكم خلاص ما راح تنسوا الموضوع، مو صعب. لا هو قلت دكتوره مثلا بالاي ار انا اذا اشتغل ومغسل يعني لابس شيف دا اشتغل على مريض اخيط به، واقول له للنيرس جيب لي خيط، يروح نيرس يجيب. لما الطبيب ما راح يروح الطبيب يجيب، راح يكتب ريكوست للاهل يجيبون من برا المستشفى او للصيدلاني يصرفوا من الصيدليه، فراح الطبيب هو يكتب ريكوست. غالبا الطبيب الوحيد اللي يكتب ريكوست داخل المستشفى، ما حد غيركم يكتب ريكوست ترى، يعني الطبيب الوحيد اللي يستخدم القلم. فلما الممرض يروح للصيدلاني يقول له اريد خيط 4 اصفار، الصيدلاني يجره وينطي، بس الطبيب ما راح يروح، راح يكتب ريكوست. فلما يكتب ريكوست يبين المشكله، يبين الخلل بالضبط. فهاي طريقه الكتابه، 3 اصفار 4 اصفار، هو يسموه 3 صفر او 3 اصفار، يعني هن اثنيناتهم نفس المصطلح. فلما نقول هو هاي الطريقه الصحيحه 3 خط صفر، يعني وراها اسم الخيط نايلون فيكرول بي دي اس او غيره زين. وغالبا هو لو سلك هو صح سلك معناه خيط، بس هو نوع معين هو اسمه سلك اللي زين، او نايلون او فايكرول. يعني هي هاي الاشياء اللي راح تواجهها. غيرها البي دي اس والاثيبون والبرولين هاي يعني نستخدمها بالعمليات. وممكن حتى لو تجيكم مجرد انه اسال دكتور شنو السبيل مال البرولين، راح يقول لك اياه، مو مثل ما تقول لي شلون اكتب 4 اصفار، واضح؟ يعني هذا سؤال عادي، ذاك سؤال شوي مو عادي. فهاي الفكره سايز تايب نيدل تايب. هذا الكيت او هذا الليبل اللي راح تشوفوه على الخيط. فممكن يقول لك دكتور هذا الخيط اللي بيدك ايش قد؟ انت لازم خيط بيدك، فيقول لك دكتور هذا الخيط اللي بيدك ايش قد؟ يفيدنا لو ما يفيدنا؟ فلازم تجاوب. يعني انت كطبيب يجي المريض يقول لك دكتور هذا الخيط اللي وصوني عليه، انت راح تقول لهم شنو الخيط اللي وصوكم؟ تقرا الريكوست اللي هي 3 اصفار نايلون مثلا، وراح تشوف هذا الشكل هذا. فلازم تعرف انه انت شنو اجزاء هذه مكتوب شنو، وشنو اللي تحتاجه منه وشنو اللي ما تحتاجه. اللي واضح من هاي الصوره انه احنا عندنا اول شيء الشيب اوف ذا نيدل اللي هي هذا المثلث. سو ات از ا ريفيرس كاتنج، هاي ريفيرس كاتنج نيدل. اوكي. و ايثيلون اللي هو نايلون يعني زين. والسايز مالته ويعني الخمسه اصفار الرقم اللي هو 5 0 5 5 0 يعني 5 اصفار، واضح؟ انه هاي الفكره يعني. فانت اللي يلزم هذا الخيط بيديكم يعني باكر عقب يلزمه بيده راح يميز انه هذا الخيط 5 اصفار وكاتنج نيدل واسمه نايلون. واضح؟ فراح تقول لي دكتور انا عندي بايدي خيط نايلون اللي هو هذا الشكل، شوفوا سموث يعني لوكس سموث وناعم كلش لان 5 اصفار. واضح؟ يمكن سؤال هيك يعني جاست تو نو انه شنو الفرق بين ال3 اصفار وال4 اصفار وال5 اصفار لحد ال10 اصفار هو خيط موجود. صح ايش قد يعني هو شنو هاي الاصفار شنو معناها؟ صح ايش قد يعني شنو القياس؟ هي مو مليمتر يعني هو لها قياس خاص، هو يو اس اي measure of the thickness of the thread. اوكي وهو تقريبا انا دورت صراحه هو عندهم قياسات خاصه يعني هو معروف ال4 اصفار هالقد الدايمتر مالته هم يعرفون، بس كمثال يعني كفكره يقل 20 ل 30%. يعني ال4 اصفار عن ال5 اصفار نقص الحجم 20 ل 30% مو نقص 10 اضعاف. واضح؟ يعني مو زادت الاصفار يعني 0.00 اصفار او 10 اصفار هاي. بالضبط بالضبط هو يعني انا ما بالي صراحه يعني زين. كل ما يزيد عدد الاصفار كل ما يصغر، بس ما يصغر بمقدار 10 اضعاف الى 20 ل 30%. واضح؟ يعني هسه فرق ممكن 2 صفرين عن ال5 اصفار او ال6 اصفار هو يعني يصير 10%، يعني عفوا يعني يصغر الى 10 اضعاف. واضح؟ ال10 اصفار هو كلش ناعم يعني فور مايكروسكوبيك سيرجريز يعني تقريبا يعني انا عامل من الشعر بهواي صراحه، يعني ما غالبا ما راح تتعاملون به، راح تتعاملون به غالبا هو من الصفرين الى ال5 او 6 اصفار. يعني ممكن بالطوارئ اذا فت فيشيال تروما او خصوصا around the eye the eyelid the ENT and the ophthalmologist and the plastic or the maxillofacial they are using these threads. شكرا جزيلا.